I am so pleased to introduce Dr. Sarah Matthews. She's a family nurse practitioner. She has additional training and certification in dermatology nursing. She's an assistant professor at UW Department of Child, Family, and Population Health Nursing. And she has directed the Family Nurse Practitioner Doctor of Nursing Practice Program for quite some time. In her clinical practice in dermatology at Kaiser Permanente, Washington, she cares for individuals with complex chronic skin diseases such as psoriasis and atopic dermatitis, as well as a variety of benign and malignant skin lesions. Great expertise. Her research has involved the use of ultraviolet to treat photoresponsive immune-driven dermatologic diseases, and this has led to an interest in vitamin D and its effect on the immune system, the microbiome, and the gut. So welcome, Dr. Matthews. She's going to be talking with us today about common skin lesions in older adults.
All right, well, thank you so much for having me. Dermatology is my passion and I love talking about it, so I really appreciate the invitation. So today we're talking about common skin lesions in older adults. And let's see if I can forward my slides, there we go. First we'll talk about just some general skin changes related to aging, benign skin lesions, and then pre-malignant and malignant skin lesions. So, as we know, there's lots of external influences on the skin, aging, and in general, we think of the excessive amount of sun many people get as being very damaging to the skin. But in my research, I have a great appreciation for ultraviolet also and the benefits it can have, but that's a balance. And definitely too much sun can be really damaging to the skin. Tobacco is really damaging, and then a healthy diet and exercise are really good for the skin. So we're going to be talking about a few of the ultraviolet related skin damage that people often experience. And these are the topics we're going to cover. Of course, there's wrinkling that occurs because of facial expressions, but also overexposure to sun and smoking. Solar lentigines are one of the most common skin lesions that we see in older people. Sometimes people refer to them as liver spots, but we really don't think they're related to the liver. They're really related to the sun. And they tend to just be very flat, brown, tan colored lesions on sun-exposed areas, mostly the face, arms, legs, the back, the chest. You know, more than half the people over 64 are going to have at least one, if not many, solar lentigines. But do be aware that if a single one stands out different from the rest, you do want to be thoughtful about whether that might be a lentigo maligna, like this spot on the back of this person's neck. And lentigo maligna is a melanoma in situ. And so definitely if somebody has a lot of brown spots, but they have one that sort of stands out differently from the rest, definitely consider biopsying that. So another common lesion is these white spots that are caused by ultraviolet damage, affecting the melanocytes, the pigment-making cells, where they just quit making pigment instead of making excess pigment. So people tend to get these white macules scattered on the chest, sometimes the upper back, very common on the arms and lower legs. They're totally benign and not anything to worry about, but a sign of having too much sun. And then telangiectasias, which are dilated blood vessels, and these are really due to the sun damaging the collagen in the vessels. And they can also occur because of rosacea and some other conditions, but even with rosacea, the thinking is that sun has a lot to do with this problem that occurs with rosacea. And then thinning of the skin is also really common and really related to sun damage. And you see this a lot in the sun exposed areas like the forearms and the hands. And the skin is much more susceptible to tearing and bruising. And so people tend to get a lot of these solar purpura. also called senile purpura, just because they're related to aging. But the thinking nowadays is that this really is a sun-related issue. Definitely, again, from the collagen being disrupted from the sun, but sometimes you do see this more in people when they're taking aspirin or other blood thinners, that, you know, the skin is really frail. These are usually asymptomatic. They're just purple, but they're not tender like a regular deeper type of bruise would be. And venous lakes are also common, and these are due to the sun damaging the veins again, and they become enlarged like a varicosity, and they can be sort of this lake or pool of blood, and they can occur in places like the lip, and they sometimes bring a person in, they're worried about these, thinking that maybe they're dangerous, and they're not. But if you have any doubt about what it is, you may want to biopsy it or refer the person for biopsy. It's a little bit trickier to biopsy the lip, so you might want to refer them to dermatology, but definitely if you're comfortable with it, go ahead and do it yourself. Comedo, or blackheads, are another thing that can occur because of sun damage, and I'm often explaining this to patients. You can see this person has really small ones around the eye area here, and then this person has much larger ones. And these are again from sun damage. Usually that's pretty mild and not really anything that needs to be treated, but if it's bothersome to the person, they can be extracted, although they often recur. But tretinoin or Retin-A cream is an effective treatment. Drying or cirrhosis is very common with aging of the skin, and this causes the skin to be really rough. Sometimes people think these are lesions, these little dry patches, but this really is just dry skin. And as we age, we have fewer oil glands and fewer sweat glands. So dryness of the skin is extremely common and can lead to dermatitis, where people get these round nummular lesions or circular lesions. And that is really from, you know, the dryness, and often scratching related to itching will make these even more erythematous, and they can become thickened and really look almost like lesions, but they are a form of dermatitis, and the secondary infections with staph are common. So, you know, preventing aging of the skin, we can't prevent it completely, but we can try to slow it down. And so, you know, just minimizing sun exposure with appropriate clothing, sunscreen, sunglasses to protect the skin around the eyes. Definitely consider vitamin D supplementation, because people can become very low in their vitamin D levels here in the Northwest, especially. That in the winter for every location for the most part. And of course, avoiding smoking, and then, you know, eating a healthy diet, staying hydrated, and exercising. So we're going to move into benign skin growths here. We're going to cover these very common skin conditions. So seborrheic keratoses are one of the most common things. It says 88% of people will have seborrheic keratoses after 64. And I feel like just about everybody who walks in the door in dermatology from midlife on will have at least one seborrheic keratosis. And these are considered genetic. We really do not believe that they're affected or caused by the sun, because they can happen in places that have never seen the sun. The only place they don't occur is on the palms and soles. And they are, they tend to be kind of these waxy brown or tan lesions that feel kind of warty, and they're really on the top of the epidermis, so they sometimes just flake off. And they're not dangerous at all, but if they are changing, they're bleeding, they're hurting, they're becoming black, definitely you want to consider biopsying them, because it could be that there's a melanoma that just appears to look like a seborrheic keratosis, or it could even be what we might call a collision lesion, where you have a skin cancer growing right next to a seborrheic keratosis. And one thing to keep in mind, though, is that these, because they are generally just benign lesions, they're not next to a skin cancer or have a skin cancer under them, they're considered cosmetic, and they usually are it's going to cost the patient out-of-pocket expense to have them treated. And the only way that you can rationalize treating them at no cost to the patient, or just their copay or whatever, is if they are inflamed, and you are sure to document that in your note that they're inflamed and symptomatic. But do remember that, or do be aware that they can scar if you treat them with liquid nitrogen. I do sometimes recommend that people use moisturizers with something like a chemical peeling agent like lactic acid to help smooth them. This is a form of seborrheic keratoses called Stucco Keratoses, and this is how they look on the ankle, these little teeny white papules that are kind of scaly. And that's the most common area for these Stucco Keratoses is the lower legs, ankles, and feet. And they can be gray to white in color. Again, I often recommend moisturizers that cause kind of a chemical peel just to smooth them. Cherry angiomas are also really common, and these are a vascular lesion, and people often end up with many of these. It's not unusual to see seniors with 50 to 100 of these, and they're bright pink to purple in color, and they're not dangerous in any way. But if a person really wants them removed, it is an out-of-pocket expense unless they're symptomatic or concerning in some way. But they can be treated with cautery or surgery or laser. Moles, another very common thing that increases with age. And the number that people have is somewhat genetic. They tend to run more in families or sometimes environmental factors. They peak most often in the third decade. We tend to get fewer of them after that, but you can get new ones as an older person. But new growths in the 60s or older, you definitely want to be more concerned that they could be a skin cancer. So keep that in mind. And if a person has a lot of these, then like maybe over 50, that can be a sign of a risk factor for melanoma. But most of these are benign. Melanomas sometimes arise in a nevus or a mole, but they can also be just on normal skin when they show up. But definitely if, let's say, a person had these brown spots around and then they developed this darker one, larger one, that might be something you'd want to biopsy. Skin tags, this is another thing that's extremely common, and lots of times people come in wanting to get rid of these. They're benign. They tend to be pedunculated like this, where they have a very small stalk that attaches them to the skin. They tend to be in places that rub, like the neck, armpits, and groin area. And 50% of people have these. They're very common. Removing these can also be an out-of-pocket expense. You can clip them off with tiny little scissors, like suture removal scissors, but they do bleed quite a bit actually when you do that frequently. So be aware of that. They can be frozen off. But in a place like this, like on the eyelid, you want to be extremely careful because the eyelid is such thin skin. You can potentially, if you use liquid nitrogen here, potentially be at risk of injuring the eye. These sebaceous hyperplasia are often confused with basal cell carcinomas, potentially. If you have a tool like a dermalite or dermoscopy, you can, a dermoscope, you can look at them close up and tell that they look kind of like yellow cobblestone appearance. It's hard to appreciate that in this picture, but you want to be sure that that you can tell that that's what they are. Otherwise, you might need to biopsy these to be sure they're not a basal cell carcinoma. But they are benign. They're basically an enlarged oil gland, and they're not dangerous, but they do sometimes bother people. They can be removed with things like cautery, but that can leave a scar potentially. And people do sometimes try Retin-A or that kind of a product, but it's only sort of minimally effective. Then epidermal cysts, we don't necessarily think of them as lesions, but they can appear to be a lesion, and they really are a plugged hair follicle oil gland that's caused the liquid oil to become solidified in there. And these are very, benign. They're not dangerous, but sometimes people will squeeze them and try to get the substance out of the inside, and that leads to inflammation, and then they become painful and maybe even infected and quite symptomatic at that point. And then they might need to be surgically removed. This one is quite close to the eye. They tend to be compressible, kind of smooth, mobile, cystic lesions. And so usually they're fairly easy to diagnose. When they're removed, you want to remember that you don't want to do it while it's inflamed. If there's a history of them being red and warm and draining, then that's definitely something you want to wait to resolve before you try to surgically remove it. If it appears to be infected, antibiotics are sometimes necessary, but often it's just a lot of inflammation because the body is having a response to a foreign body inflammatory response. We do sometimes just monitor them, or frequently we do. It's good to be aware that insurance will usually not cover removal unless they're over 2 centimeters, which is a pretty good size. People sometimes want them removed before that, but it's important to know that you can end up with a pretty significant scar when you remove these. So sometimes people decide that they'd rather have the bump than the scar. But for it to be curative when you remove them, you have to be sure to remove the entire cyst. If you just remove the contents inside, then usually they'll just regrow. So they need to have the inflammation calm down, possibly with antibiotics, and then consider excising after that. All right, so now we're going to talk about some skin cancers. This is meant to show you that the actinic keratoses, which are precancers, are by far the most common. The basal cell carcinomas and squamous cell carcinomas, including squamous cell in situ, is the next most common, and melanoma is the least common. So it's always really important to think about the history of a lesion when you're considering whether you want to biopsy it. So, asking about the length of time the lesion's been present, has it been growing rapidly? Is it changing color? Is it bleeding, itching, or painful? Those kinds of signs would all be things that would make you consider biopsying. And other things that when you're thinking about how at risk a person is of having a skin cancer is whether they've had a skin cancer before, whether they've had precancers, actinic keratoses, and whether they've had a history of severe sunburns, tanning, lack of sunscreen. Radiation is another risk factor. At the site of radiation, you can definitely get more skin cancers. Also, if there's a family history of melanoma, studies have shown about 1 in 10 patients with melanoma will have a family history. And they're 50% more at risk if that person is a first-degree relative. There are these gene mutations, the P53 and BRAF, that are associated with familial melanoma. People with atypical moles and a family history of melanoma are the ones that are at greatest risk. So they need to be watched much more closely, or, potentially have biopsies, have a higher rate of suspicion for any moles that they have. So actinic keratoses, these are considered precancerous, or some would say this is the earliest form of skin cancer, where it's in situ, just very superficial dysplasia. And these occur in sun-exposed areas where people have had the most sun damage. 80% occur on the head, neck, dorsal hands, and forearms, although some people have a lot on their legs if they've done a lot of outdoor activities in shorts. And they tend to be tan, sometimes more red, keratotic, with this thicker scale on them. They might be slightly elevated, but generally they're pretty flat. Sometimes they can be a little bit more shiny. They can be tender and less commonly itchy. And they are often easier to feel than to see. So I'm often just touching a person's face when I'm examining them. They tend to be 3 to 10 millimeters in size. If they're greater than 6 millimeters and there's more of a palpable dermal component, so the skin feels thickened, then they could be a deeper, skin, or a thin skin cancer versus being really at a precancer level, and or maybe even a full-blown skin cancer. So definitely would consider biopsying that lesion to confirm the diagnosis. And especially if you've tried liquid nitrogen to treat one of these and it's not getting better, then consider biopsy. Risk factors definitely are just a history of having actinic keratoses. As people age, the higher risk, and men in general have more actinic keratoses. 1 to 4%, it's estimated, will actually become a full-blown squamous cell carcinoma if not treated. And people who have actinic keratoses probably have about close to 6 or 10% chance of getting squamous cell carcinoma if they have these actinic keratoses. So sometimes if a person is older, let's say they're in their 90s, I sometimes have a conversation with them about whether to treat or not to treat, because, if you're older and there's only a 1% chance that one of these will become skin cancer in the next year, or a 10% chance in your lifetime, and you're already in your 90s, the chances are pretty low. So you don't necessarily need to be aggressive about treating them. But, that's really a shared decision making process, discussing it with the patient about what their goals are and how they feel about being treated. And it's good to know, I always tell patients that 20 to 25% will resolve spontaneously if people really protect themselves from the sun. So sometimes people even notice that these come and go. And it's probably because their own immune system is trying to fight them off. And so if they're really protecting their skin and they're healthy, their immune system is intact, then some of these will go away spontaneously. And do remember that even though these are much more common in lighter skin types, darker skin types can get actinic keratoses. So you always want to be watchful, even if somebody has more natural pigment. Usually we treat these with liquid nitrogen, especially if there's just single isolated lesions or a few of them scattered around. But we do also use field-directed treatments, which is more helpful if there's just, diffuse actinic damage. And, you know, and treating with liquid nitrogen, spot treating would not really get at all of the damage the person has. And, you know, usually you can tell by just sort of feeling the skin again that there are some that are subclinical, but lots of times you really can't even see them with the naked eye. So if somebody has, you know, a fair number of these, or they're just, you know, very recurrent, I think about topical medications to do more of a field treatment, as we call it. 5-fluorouracil is a chemotherapy cream. That drug has been used for internal kinds of skin cancers, and originally they discovered it for, or the internal other cancers. They discovered it for skin cancer when they realized people's skin was getting better when they were being treated with 5-FU for internal cancers. And now it's a cream that is applied for like 3 weeks on the face and maybe 6 weeks on the scalp or other body areas. And it can be very, very effective. And it really just treats precancer lesions and superficial skin cancers. And it can really help prevent skin or precancers for years after using it for one course of treatment. Imiquimod is an immune modulating medication that can also work well. There's also chemical peels and photodynamic therapy, which is PDT, where people get a solution applied to their face that or other body areas potentially that make them very photosensitive, and then they get treated with a laser kind of treatment, and they get what looks like a severe sunburn within the next day or two, and then everything peels for a few weeks after that, and it can be quite effective. Usually these treatments are done in dermatology. So it's good to be aware of how effective liquid nitrogen can be. It really can, you know, be up to 99% effective. These are some studies. I won't go into too much, but you can look at these results. But it really depends on how effectively you freeze the lesion. You have to be aware that you're trying to have the lesion frozen for at least 10 seconds usually. With 5 seconds, it's only going to be 39% treated according to this particular study. If you do it for 20 seconds, it's like 83% up. Lots of times I'll do 10 seconds and let it thaw and do 10 more seconds. You do have to be careful because you can scar a person with liquid nitrogen. So you really want to be thinking about how thick is the lesion, you know, where is it located, you know, how sensitive is it cosmetically. Some places do scar much more easily, such as the arms and the chest. They actually scar more easily than the face. That said, people are going to be more worried probably about a scar on their face than they are on their arm. So it's something to keep in mind. Again, you want to have a conversation with the patient about that prior to doing the treatments. Always talk about scarring as a potential risk with liquid nitrogen. But you have to balance that with the fact that you want to get rid of it in order to prevent them from developing a skin cancer. So now we're going to talk about the other skin cancers that are more common, the basal cell and squamous cell. So risk factors for skin cancers, again, chronic sun or even bursts of sun. The bursts of sun are really highly associated with melanoma and basal cell carcinomas. Tanning beds are also associated with melanoma. Radiation, as I said before, can be associated with skin cancer, HPV from the wart virus. And this, we do see even more in transplant patients that are immunosuppressed or people that are on immunosuppressing drugs for other reasons. We tend to monitor much more closely because they're more at risk of HPV, leading to more skin cancers. Definitely smoking is a risk factor, especially for squamous cell carcinoma. And so I always encourage people to quit smoking. As I said, immunosuppression including, HIV, AIDS, and just being on medications for other things. Immunosuppressive medications can definitely make people more at risk. Always keep in mind too, if someone has a chronic non-healing wound, it may develop a skin cancer, or may be a skin cancer that people have thought was just a wound related to something else, such as venous insufficiency or arterial disease or diabetes or something like that. So basal cell carcinoma, this is definitely the most common skin cancer in Caucasians. African Americans and Asian Pacific Islanders are lowest risk, but definitely still at risk. I've seen basal cell carcinomas in all different ethnic groups. And the rate really increases a lot with age. The incidence is increasing in people under 40, though. We're seeing this definitely in younger people now, but it tends to be people who've had too much sun or tanning. But it's very common in older people, and these grow very, very slowly. I had somebody come in the other day who said, wanted their moles checked, and they had a bump on their forehead that they said, oh, I've had that for 10 years. And that was not the person's concern. They were concerned about moles, and it turned out they had a good sized basal cell carcinoma on their forehead. So do be aware that these can grow slowly. So sometimes people think something like this on the nose is just a mole they've had for a long time. Turns out it's a basal cell. So the median age is 69, so definitely something in the older population. And once somebody's had one, you want to know that close to half, 40%, will have another one within 5 years. So you watch them very closely for the first 5 years. And be aware that this one that's really dark, you might think, gosh, that looks more like a melanoma. This is what's called a pigmented basal cell carcinoma. And you might not be able to tell just visually, but you do want to biopsy this one way or the other. And this is kind of classic basal cell, where it's got this rolled border. And then they can just be these papules with these telangiectasias, vessels dilated. Superficial basal cells can look more like this, where it's just kind of a flat red patch that won't heal, won't moisturize away. This again is a nodular basal cell. This is probably a superficial basal cell. So the mortality rate is really low because these are locally invasive, but not, there's only more rare types that metastasize, but they can locally destroy muscle, cartilage, so they can be disfiguring if not treated. About 70% are going to be on the face or head. Biopsy is the best way to confirm exactly what it is, and then know what subtype it is, so that you know exactly what type of surgery the person is going to need. The cure rate is really high. And again, as I mentioned earlier, these are really often related to sunny vacations, bursts of sun, and especially in adolescence and childhood, but definitely chronic exposure can be a factor. As I mentioned, melanoma is also related to bursts of sun, and this incidence is increasing worldwide. These are the more rare types that are high risk. One thing to be aware of is that infiltrating basal cell carcinoma often looks like a scar. The sclerosing also can look like a scar. And these, sometimes if somebody says, oh, I asked how long have you had this scar? What caused it? And they're like, I didn't know I had a scar there, or I have no idea what happened there. I often will biopsy that scar, because I have found quite a few times that what looks like a scar that has no history of being related to trauma is actually a basal cell carcinoma. So it's good to be aware of that. Another thing to be aware of is if somebody has like a neurological symptom, that like a feeling of a nerve being tweaked in their forehead or something like that. That also I have discovered is actually a skin cancer in the nerve. So be aware of that also. So any of these, if you saw any of these after doing a biopsy, you'd want to be sure this person gets to dermatology because they're probably going to need a bigger type of surgery. So the most common surgeries for basal cell carcinomas, and I won't go into all these details, but like electrodesiccation and curettage, ED&C is very, very commonly used. And that's what for basal cells that are low risk sites like the neck, trunk, and extremities. And that is essentially where you numb up the area, you curette the lesion. The cells of basal cell are much softer than healthy cells. So you just curette away all the soft cells and then cauterize the area and curette it again and cauterize and curette. It's like 3 cycles of that. Can be quite effective. They need to be smaller, like under 10 millimeters. And again, you know, in these low risk areas. Sometimes we'll do it in higher risk areas if the person maybe isn't going to tolerate a bigger surgery, or they're older and they don't want to go through Mohs surgery or something like on the nose or ear, but they can definitely be more at risk of recurrence. Surgical excision, we definitely do those too for trunk extremity and smaller basal cells. And, you know, that's 95% cure rate. And then there's Mohs surgery, which is where you take layers until you're sure that the physician who's trained in Mohs surgery looks under the microscope themselves and can see whether they've got the whole tumor, or they go back and take another layer and they keep doing layers till they have all of it. And that really gives the best cure rate and also the best cosmetic result because they don't take any more than they need. And this is usually done on the face, ears, and scalp. And what we call the T-zone on the face is really around the eyes and the nose and mouth areas. So squamous cell carcinoma is also very common, considered the second most common. And this is a Bowen's disease, which is also just another name for superficial squamous cell carcinoma. And these I've seen being treated with like triamcinolone or, you know, a topical steroid for sometimes a long time, months or years, and not healing. And they turn out to be a skin cancer. So definitely anything that's prolonged isn't responding to treatment should be biopsied. They can develop from actinic keratoses that are not treated. They tend to grow slowly and they tend to be kind of growing horizontally versus down, but they definitely can progress to being invasive squamous cell carcinoma. These are usually treated with those like chemotherapy cream I was mentioning before, the 5-FU, 5-fluorouracil, but they can be surgically treated too. Usually, if someone's older, I'm more inclined to do the cream, but it really depends on the location and the person's tolerance and desire. One thing to be aware of is that the 5-FU can be fairly expensive if people don't have a good coverage for their medications. They can be several $100s for a tube. This is a squamous cell carcinoma on an ear on the mid-helix. The median age for full-blown squamous cells is 75. The majority of deaths from this skin cancer is from the ears because of the blood flow from the ears into the neck can increase the risk for metastasis. So you want to be aggressively managing ear lesions. They tend to be erythematous papules or plaques or nodules. Sometimes they have a crust on them or an ulceration. The scalp is a very, very common place for these. As I said, SCC can metastasize, and the scalp is another higher risk area. These are also more common in men. And these are more often due to more chronic sun exposure. They're more common in fair-skinned people, but it's good to be aware that definitely people who have naturally more pigment can still get squamous cell carcinomas. So you really want to be watchful of lesions like these on this person. I would biopsy these. And this is probably a leg or an arm, but these are most common on the ears, lips. You can get them on the genitalia and scalp, probably on the genitalia from either sun exposure or HPV can put people more at risk for the squamous cell. And these are the more common thing to maybe show up in a chronic wound or scarring, like a burn scar could be more at risk for developing squamous cell carcinoma. So be aware of that. Always biopsy to confirm the diagnosis. When you're biopsying these, you can do a shave, but you might miss the lower part that is more invasive, and then you might not get a firm diagnosis. So, you know, a punch biopsy or excisional biopsy down to the deeper, you know, as we call mid-reticular dermis is preferred. These definitely can be cured 90% of the time, but there's a higher potential for recurrence and metastasis than basal cell. So you know, usually you want to get the squamous cell carcinomas in for surgery quickly. You know, we usually try to do those within 2 weeks of diagnosis. Because a delayed diagnosis could definitely lead to more risk for morbidity or recurrence somewhere else. And these are treated with the topical only when they're the Bowen's disease, when they're the superficial type. Otherwise, you're going to want to do a surgery or excision and radiation therapy. Sometimes if they're an older person, they're not surgical, or you know, the poor person is more at risk of deeper skin cancer. So there's about 50% risk of another non-melanoma skin cancer after the first one within 5 years, so a little higher risk than basal cell. So careful follow-up. Usually we do follow these folks, you know, every 6 months for at least several years, and then we'll go to a yearly follow-up long-term. And yeah, often I will see them at 3 months after the first one, and then 6 months for a couple of years, and then yearly. So melanoma, this is a nodular melanoma. These arise in the melanocytes, pigment-making cells. The incidence of these is increasing as well as the death rate. It is the most preventable cancer and the fastest growing preventable cancer. And we're seeing that more in younger people. The most common sites are on the back and the lower legs. We definitely see these a fair amount in older patients. And, you know, major risk factors include having a high number of common nevi. As I mentioned, if somebody has 50 or more, you definitely want to be really monitoring that person. If they have one or more atypical appearing nevi, certainly the light skin phenotype makes the person more at risk, but I'll show you later that darker skin types definitely are more at risk of the kinds of melanoma that occurs on the palms and the soles and in the mouth. Certainly if the person has a history of burns, you want to be watching them more closely and counseling them more. The question I tend to really focus on with most patients is, you know, whether they've noticed any new moles or changing moles, or whether their significant other has. Frequently for men, it's that someone else has pointed it out to them, because men are less observant of their skin or concerned about it. And often it's somebody else who's told them, go get that checked. Certainly a personal or family history, as I mentioned before, of melanoma. Full skin checks for melanoma do require good lighting. It really helps if you have a magnifier to look at things close up. And I think they should be integrated into full physical exams. But if you're not comfortable with that in primary care, you know, definitely sending somebody to dermatology is very reasonable. I do talk to patients about the ABCDEs and the ugly duckling sort of thing. I say, you know, if there's one mole that's standing out from everything else, it just doesn't fit in, any kind of growth like that, you want to get it checked. But these are the ABCDEs. You're probably familiar with these. A for asymmetry. So this is very symmetric, whereas this, it's darker on this side, lighter on this side. It's longer this direction than it is this direction. So definitely that is a concerning sign. B for border, an irregular border. D, oops, I skipped C. C for colors. 3 colors is definitely something that should make you suspicious. If it's, you know, dark brown, light brown, and white, or gray and pink and brown, you know, definitely multicolored is a highly suspicious sign. And then evolving is probably the most important. Usually melanoma is going to change over time, and it's going to change, you know, fairly quickly over a few weeks or a few months. But I have had some, especially lentigo malignas, that people say to me, I've had that mole forever. You know, I've had it for 30 years. But it looks suspicious to me. I usually talk them into biopsying it. And, you know, frequently they are lentigo maligna. If they've been there for many, many years, but they're starting to look suspicious, that is more likely a slow growing lentigo maligna. Something that's moving quickly is a more aggressive melanoma and definitely deserves a biopsy. And it's good to remember that melanoma can occur in, you know, all skin types. So, you know, this is one of those things you should really be thoughtful about. If somebody has what looks like a wart on the bottom of their foot, you know, if it looks brown, discolored, you know, that's something you're going to want to really be thoughtful about and consider biopsying, because it could be not a wart, but a melanoma. And melanoma, acral melanoma, is more common in darker skin types. So always looking at the bottom of people's feet and their hands. The average age of this acral melanoma is 60 to 70 years old. And it's the most common subtype in darker skin individuals, but it can happen in lighter skin types too. Again, the palm soles, under the nails, and in the oral mucosa. Non-hair-bearing areas. Doesn't have to necessarily be sun exposed, although people often do get sun on the bottoms of their feet when they're lying down in the sun. This is the most common type of melanoma diagnosed in Asians and sub-Saharan African ethnic groups. This is acral melanoma on the finger. You can see on, you know, here's a light skinned person too. And the way that you often will pick this up is that you'll see it not just in the nail, but in the skin. If you see the pigment spreading onto the skin, then definitely suspect melanoma. Sometimes longitudinal lines in the nails can be normal, but if you see any change on the skin, you've got to get that checked. And let's say this person said, oh, I think I banged my thumb. You'd want to follow this really closely and make sure this resolves if it's a bruise. And if it's not resolving, it needs a biopsy. So early detection is super important. All right, so melanoma screening, you know, is really based on risk. You know, as I said, if a person has multiple atypical nevi or a history suggesting familial melanoma, that's somebody you're going to want to be following closely and you know, biopsying maybe more freely. A moderately high risk person might be just white men over 50, just because that's a higher risk group, or an individual with a history of significant sunburns or multiple moles. If they're high risk, you know, they definitely should be getting full skin exams regularly by a skin expert or someone who's just really comfortable doing skin exams. You know, self-monitoring is really, really essential because a lot can happen in a year. So I tell people, you know, to be looking at their skin once a month and really, you know, even taking pictures with their phone if they, you know, aren't sure if something's changing or they can't see their back well, you know, getting help with from someone else taking photos can help. And of course, using sun protection. And definitely people can have a genetic type of melanoma risk, but we don't really do genetic testing to determine a person's risk because usually you can tell just from the familial pattern. And either way, you're going to want to watch that person closely. The USPSTF doesn't really recommend regular skin exams unless a person is identified as at risk, but you definitely need to be, you know, asking some questions to really determine a person's risk over time. So in summary, the incidence of melanoma is definitely increasing faster than any other preventable cancer. Mortality rate among white men over 65 comprises 36% of all deaths, more than double over the past 30 years. And, you know, risk factors for melanoma probably really are a combination of environmental and genetic. Majority are detected by the patient or often their spouse or another friend. And the highest yield for full skin exams is in men over 50 years old, but we certainly do a lot in women too. And if they're detected in a routine clinical exam, they often are thinner than those detected by their patient or partner. But it's still good to really educate the patient and the partner on what to look for. And as I mentioned earlier, men often find these later than women, so there's a poorer survival rate. But there may also, maybe there's a genetic component with gender that we haven't identified yet, but we think it's more of a behavioral thing. But definitely skin awareness, skin exams, and you know, sun protection are key. So I think we actually are done a little bit earlier, but I'm happy to take questions.
That was magnificent, Sarah, and we are done a little bit early, but I do have a question. Judy is wondering if there should be a concern for mild areas of redness, maybe unresponsive to steroids and starting in one place and appearing in other areas later. She thought that unresponsiveness to steroids seemed like maybe a red flag for dermatitis.
Yes, it could definitely be dermatitis. You know, and even though it's not responding to steroids, you know, usually dermatitis will respond to steroids, but that would definitely refer that person because there's lots of different skin conditions. It could potentially be skin cancer, but also just a variety of different, less common skin conditions that are not as steroid responsive.
So Mary is curious what you know about the solar screening fabrics and clothing. She said she thinks one advertises being as effective as an SPF 50. Is it a chemical on the cloth? And if so, does it eventually wash away?
Yes, I think it's a combination that they use. One is a much tighter weave than some clothing. And so that's an important factor that helps that clothing be sun protective. And then there is a coating that's put on. So I think there is a limit to how well that coating stays on with a lot of washings. So I often recommend that people consider, getting new sun protective clothing periodically, but also to wear sunscreen underneath the sun protective clothing and not just depend on the clothing. But I think the double protection is much better than just sunscreen, because often people don't put enough sunscreen on either. Mm-hmm. Or it washes off as they're, out snorkeling and that kind of thing. So I do really like sun protective clothing.
Do sunblocks become toxic after expiration?
Well, there's a lot of debate about sunblocks and toxicity. I do recommend for people, especially people that are sensitive to sunblocks, I think the physical blockers like titanium dioxide and zinc are safer. In general, they're not as absorbed as the chemical sunblocks. And some people, I think, really should even use the baby sunblocks, the ones that are designed for babies, because they're the least toxic. I think in general, the ones that have titanium and zinc are the safest ones to use. And if the thing about expiration is more that not necessarily that they become toxic, any more toxic than they ever have been, but that they just become less effective because the compounds start to break down. So I would definitely buy new, fresh sunblock every year.
Is that recommendation about baby sunblock maybe particularly appropriate for older adults given their skin changes, or what are your thoughts?
Yes, I think that's true because they may have a reaction to the ones that are chemical blockers. They're maybe going to get more of a dermatitis, a contact dermatitis from some of the ones that have some of the more irritating components. So I like this baby sunblock for older skin.
Well, this was just really helpful. I'm also thinking about some of our attendees who are in agencies and that sort of thing. If somebody, if an older adult were to come to them and ask them, or point out some lesion or another, do you have any guidance that they might use to say primary care provider versus dermatologist, check in with?
Yeah, I think it's always fine to go to your primary care provider because you might get in faster, frankly, because often dermatology is backed up and waiting might be a bigger problem. And usually primary care is either comfortable biopsying or they can consult. In my agency, Kaiser, we have teledermatology where the primary care provider can send a photo in and a brief history and get advice from the dermatologist. And then if dermatology feels like they need to see the person, then they're going to work them in quickly. And that can happen even just with a phone consult with dermatology if you're concerned. So definitely if a person has a dermatology provider and they can get in a timely way, that's great. But there's definitely no reason not to go to primary care and get advice there first.
Well, that's helpful. Let's see here. Are there effective treatments for scars generally, and specifically scars may be caused by inflamed or post-drained epidermal cysts?
Oh, that's a good question. There's different types of scars. Hyperpigmentation type of scarring can be treated a couple ways. We usually really recommend keeping it, any sort of a traumatic area that's been traumatized out of the sun, because the sun can hyperpigment the area. So you want to protect it from the sun, use sunblock, that kind of thing. Then you can use things like hydroquinone, which is a bleaching agent, to help fade the discoloration. There are some over-the-counter silicone type scar treatments that you can buy. Then there's also, depending on it, if the scar is more elevated and maybe even hypertrophic, then I would refer the person to dermatology, because we do sometimes treat those with steroids, either topical, very strong topical steroids, or injected steroids, interlesional steroids for both hypertrophic and keloid type scars.
Interesting. So I'm going to ask you a question that's going to reveal my ignorance, but do you want to say much about aloe, which we see in a lot of older adult households?
Yeah, I mean, aloe I think is soothing. I don't think there's anything wrong with aloe. I think people sometimes like to use vitamin E, like vitamin E capsules, and cut those and use aloe. I don't know that, I haven't read any studies that have shown those are super helpful. They're soothing, but the aloe I could say is probably more soothing. I've actually seen people get a contact dermatitis from vitamin E oil if it's applied for too long. So, be aware of that. If it seems to be getting worse rather than better, I would stop.
Okay, any other questions? This has just been magnificent, an area of expertise that not a lot of us have, Dr. Matthews. So I really, really appreciate it. And from the comments, it seems like a lot of people have really appreciated also the thorough presentation.
Oh, my pleasure. You're welcome. I'm used to getting a lot more questions throughout my talk, so I probably could have added more stuff, but I think we covered the common things that people are going to see, and the important things that, the red flags that you want to be aware of, so that you or people that your own clients can get care in a timely way. So thank you so much for inviting me. Really appreciate that.
This is great. I probably should have sort of encouraged questions throughout, but I'm always sort of keeping them to the end. So sorry, folks, if that was constraining a bit, but this was great. Thank you so much. And we'll see you all next week, next Tuesday.
All right. Thank you.
Thanks.
Bye-bye.
Bye.